It is approximately 1:35 in the afternoon. This is a joint hearing of the Senate and Assembly Health Committees. It's an informational hearing with regard to health disparities. Welcome. I'd like to just make a few opening remarks. Well, we all know that California has taken a leadership role in the implementation of the Affordable Care Act with regards to the number of individuals signed up. A third of our population are on Medi-Cal. Last week, we had a great, I think it was last week, that we had an informational hearing on the Assembly side about rates. And we're starting to look at the entire package with regard to how we're going to be successful in providing health care. But there's an extremely important element of it that sometimes, many times gets overlooked is, yes, it's important to have health insurance. Yes, it's important to have a health insurance card, but what happens if there's no access, if there is a distribution problem, or if individuals can't see a provider? But more importantly, what about the healthcare disparities that we not only have in this country, but we have here in particular in California? And if you kind of drill down, those disparities that are really, really apparent amongst various demographic groups, various ethnic groups. And so what this hearing is going to do is to, number one, look at those. And the goal is to not only be successful in the implementation of healthcare reform, but how do we reduce those disparities and change that curve so that every single person has similar outcomes, every single person has access to healthcare. And there have been many a times where I've given talks about healthcare, and there's one statistic that I always use whenever I start off some of my talks, and that's give me your zip code and I will tell you your life expectancy. And the sad part about that is most of those zip codes are in poor communities of color. And why is it that if you're African American or Latino or live in a poor community, that you have a less likelihood of living or getting access to health care? And that's what I think the goal should be of this whole endeavor with regard to healthcare reform here in California and hopefully in this country. So I'm going to turn over to the chairman of this Assembly Health Committee, Assemblymember Banta, if you'd like to make a few opening remarks. Thank you.
Thank you, Dr. Hernandez. I really appreciate your leadership, and I'm very excited and proud to be working together today on this important hearing on health disparities. And we just want to take another opportunity to tell you how much I've appreciated our partnership already this year and how I'm looking forward to the important work that we have to do together in the health field in California this year. And super excited to be talking about health disparities, an issue that's really important to me, in particular as the first Filipino-American legislator in the history of California, and with the knowledge that I have of the Filipino community not always being disaggregated for information and targeted action. It's really important that we focus not on monoliths, but on specific disaggregated data points that can really help inform the work and the action that we have. And if we take the API community as an example, there are more than 23 distinct communities within the Asian American population and 19 within the Native Hawaiian and Pacific Islander population. So the targeting and the importance of disaggregation is very important to uncover potential disparities. And I think it's absolutely important to address all types of disparities, whether it be education or economic opportunity, equal justice. And that work is happening this year in a lot of different ways. Today, of course, we're focusing on health disparities. And I wanted to also just share that I was very proud that my father and mother were both farm worker organizers with the United Farm Workers of America, and we lived in my early years in the headquarters of the UFW movement, a place called La Paz in the Tehachapi Mountains outside of Bakersfield in the Central Valley, and there my dad set up healthcare clinics for the farm workers, a very underserved community that needed the support and the targeted action. So this is something that's been important to me and my family for a very long time, and I'm also excited that I'm authoring AB 176 this year, our disaggregated data bill, which will require the State Department of Public Health and higher education institutions to use specified categories for each major Asian and Pacific Islander group for reporting and data collection. So, and also, I'd be remiss if I didn't share that I'm also the chair, along with my tremendous colleague, Assemblymember Reggie Jones-Sawyer, of the Select Committee on the Status of Boys and Men of Color, where the issue of disparities in health and other areas is absolutely critical. So there's a nice synergy with this hearing and the work that we're doing there as well. Just want to thank all of our panelists and participants, attendees in advance for your commitment to this issue and your participation in today's hearing. And thank you for the opportunity to work together.
Thank you. We're going to go ahead and move on to item number 2, defining disparities in California. If we can have all of the presenters come up, that's going to be Sarah De Guia, JD Executive Director, California Pan-Ethnic Health Network, B. Darcel Lee Harris, President and CEO of California Black Health Network, Javier Morales, PhD, Executive Director, Latino Coalition for Healthy California, Jonathan Tran, Policy and Advocacy Manager, Southeast Asia Resource Action Center, also Ayako Miyashita, inaugural Brain Belt HIV Law and Policy Fellow, Williams Institute. My understanding is that one of the individuals has to leave early, is that correct? So we will let that individual go first. I'm not sure who that is.
We'll go ahead and go in order because she's second.
Oh, you are going to go in order?
Yeah, so we'll be okay.
Because I was told that somebody might
Yeah.
need to leave early if they wanted to go first. All right, if that's the case, then we will go in order. Please state your name and present, and thank you.
Thank you so much for this opportunity, chairs and members of the committee. My name is Sarah De Guia. I'm the Executive Director of the California Pan-Ethnic Health Network. CPEN is a multicultural health advocacy organization working to improve the health of communities of color in California. This is a great opportunity to talk about this issue, this very important issue. As I was conducting research for this hearing, I looked back at some of our previous documents, and CPEN actually developed a report 10 years ago in 2005 with many of the same recommendations that we're going to talk about today. So that's how far we've been moving in this direction. But I first want to acknowledge this legislature and the administration and Covered California in the expansion of coverage to many of communities of color who were the remaining uninsured. We've made great strides in that sense. But given the persistent life-threatening disparities that communities of color face, it's imperative that we now shift towards improving the quality of care for communities of color. Many of the health disparities that communities of color face, they face them across communities and result in shorter life expectancy. Many of these are preventable health conditions. They're fueled by a lack of access to care, but also as a result of social and environmental determinants of health. Chronic stress from economic uncertainty, inability to afford healthy foods, exposure to environmental health risks. But the lack of standardized data collection and analysis efforts really impedes our ability to accurately identify the communities experiencing the greatest needs and to be able to work with health plans and providers to improve those health outcomes. My written testimony provides much greater detail about these types of disparities, but just a couple that I wanted to highlight. Asian and Pacific Islanders, Latinos, and African Americans all experience hospital visits that could have been prevented due to hypertension. As my colleague will talk about, African American mothers and babies die more frequently due to conditions in pregnancy and childbirth. Latinos and African Americans are also admitted more to hospitals and also face amputations, all preventable, but due to complications of diabetes. Students of color and women of color are more likely to experience depression and intimate-related violence. These are just a couple of the many, many more types of health disparities that communities of color face. But taken together across communities, these statistics tell a story about the institutional barriers that remain for our communities to live healthy and productive lives. It's time for change. And in this post-ACA world, the mantra is the triple aim: better health, lower costs, better quality. But we're missing a really important element, and that's equity. We need to ensure that the foundation of these three goals is health equity. Efforts to improve reform payments and delivery of healthcare service in an effort to drive down costs have to be informed by the needs of communities of color, or they could actually result in further disparities. The state, private researchers, and health plans have all utilized the analysis of data in various different ways that have been able to help us actually act on and reduce disparities. We have Medi-Cal threshold languages that DHCS is able to provide. Covered California has used enrollment data to better determine where we need to target resources for outreach and enrollment. Health plans have used disparities in an effort to improve screenings among African American and Latino communities. But again, this is across many different sectors and is done in many different ways. So we need these tools to be institutionalized. And here's a couple of steps that we can take. Number one is standardization. So we need race, ethnicity, primary language, gender identity, and sexual orientation. All of these categories to be, methods need to be standardized to ensure comparability and consistency. And of course, data needs to be collected accurately, voluntarily, and also make sure that it's disaggregated data by Asian and Pacific Islander categories, that there's actually collection of sexual orientation and gender identity. And there are some current legislative efforts that we can move forward. But also there needs to be policies and procedures for how government agencies, plans, and providers can collect this data, and also how we're making it known to the public why this information is so important so that people are able to then voluntarily provide it. And finally, data needs to be continually analyzed and updated so that we can identify the disparities, determine their causes, track them, and make sure that we're working on eliminating them. Government agencies, plans, and providers can all be using the data to develop quality improvement, and disparities reductions. And of course, beyond data collection, we also need to ensure that providers are offering culturally and linguistically appropriate care, that assessments of social determinants of health are integrated into strategies to improve health, and that we have greater coordination between healthcare delivery and supportive services. So we're now 5 years into the passage of the Affordable Care Act. We're 5 years until the Healthy 2020 goals are supposed to be met. And we have opportunities in front of us, but yet we continue to face these really significant institutional barriers. So the time for change really is now. Thank you so much.
Thank you. If we can move on to the next presenter, please.
Harris Lee.
You're good.
Is it on? Yeah. Okay. And I'm President and CEO of California Black Health Network, and I really appreciate the opportunity to speak to the committee today. Thank you, Senator Hernandez, for convening this session. Racial and ethnic health disparities undermine our communities and our health system. African Americans are the most likely to suffer from certain health conditions, get sicker, die quicker from complications than any other ethnicity on the planet. Just listen to some of these statistics, some of which I'm sure you already know. With depression, 20% of us are less likely to receive treatment. Stroke, 40% of us are more likely to die. Heart disease, 30% of us are more likely to die. Asthma, 2.1 times more likely to die. Breast cancer, 40% more likely to die. Prostate cancer, 2 times more likely to die. And with HIV, 9 times as likely to be diagnosed and 8 times more likely to die. Maternal mortality, 2.5 times as likely to die during pregnancy. And diabetes, which is rampant in our communities, 60% more likely to be diabetic and 2 times more likely to have a limb amputated. Why these disparities? They may stem from many factors, including accessibility of care, lack of health insurance, increased risk of disease from occupational exposure, and increased risk of disease from underlying genetic, ethnic, or familial factors. I am personally impacted by health disparities within the system. I have an unusual and rare disease called sarcoidosis, primarily found in African Americans and a few other people of color. That's one reason I'm leaving today, is to see my doctor, because it's gotten worse. There is not a lot of information available about the disease. It is unclear to where it comes from, and there is no cure. It can be debilitating and even cause death. Why do I categorize this disease as one impacted by health disparities? Because when I was diagnosed in the 1980s, I was told by my doctor, "I am sorry, we will not be able to do much for you. There is not a lot known about sarcoidosis because it is a disease that impacts people of color. Therefore, there's not a lot of funding available to conduct research on this disease, and probably won't be until someone white who's famous contracts it." That wasn't a very pleasant thing to hear. That scenario has not changed much in the last 30 years. So even research of diseases that impact people of color are affected by the disparities in the health system. How unfortunate is that? But today I want to focus on another health disparity in particular that is really devastating to African Americans, devastating because it impacts the future of our race. I'm talking about Black infant mortality. Our babies are dying at almost 3 times the rate than any other ethnicity, and these deaths are primarily due to health disparities. According to the U.S. Library of Medicine and the National Institutes of Health, racial and ethnic disparities in infant mortality in the United States seem to defy all attempts at elimination. Despite national priorities to eliminate these disparities, Black infants are dying at 2.5 times the rate of non-Hispanic white infants. This disparity is largely related to the greater incidence among Black infants of prematurity, low birth weight, congenital malformations, sudden infant death syndrome, and unintentional injuries. This greater incidence in turn is related to a complex interaction of behavioral, social, political, genetic, medical, and healthcare access factors. Thus, to influence the persistent racial disparity in infant mortality, a highly integrated approach is needed with interventions adapted along a continuum from childhood through the periods of young adulthood, pregnancy, postpartum, and beyond. I want to share with you a quick story as I finish. A dear friend of mine has lost 3 babies prematurely over the last 3 years. It's been devastating for her. She's pregnant again, and this time her physician has told her that she must have bed rest for the entire 9 months of her pregnancy in order to carry this baby to full term. This individual's been eating well, taking care of her health, and is tenacious about her physician's appointments. She has 4 other friends in the same neighborhood who've also lost their babies due to either preterm issues or low birth weight. The common factors: they live in a low-income neighborhood that is rifled with crime, positioned next to a water treatment plant, and is only blocks away from a train station. These environmental and social factors are believed to be impacting the ability of these women to carry their babies to full term. So I really relate to what you said, Senator Hernandez, about the zip code. It does make a difference. I share this story with you because it is important to understand that we must look at the social determinants of health as we study the issues that impact African American health across the state. We must collect more data, analyze more data, and then we must begin to develop the solutions to Black infant mortality, diabetes, HIV, and the plethora of other chronic diseases that plague our populations, and change the paradigm and create healthy families and healthy communities throughout the state. California Black Health Network is ready, willing, and able to join you and other elected officials to work on these issues. This hearing is a good beginning. Thank you so much for the time to share this information with you.
Thank you very much. If we can now move on to the next presenter, Mr. Morales.
Thank you, Senator Hernandez, and members of the Senate, members of the committee. I'm honored to be sitting here next to partners with whom I feel very closely aligned when it comes to the work we're doing to address issues of health disparities, to advance health equity, and also to advance health justice. As a matter of background, the Latino Coalition for a Healthy California has 2 large goals. I say large because each goal has an A, B, C, D, E, F, G, but we're not going to go through those. I'll keep it at the macro level. The first goal is health care for all, regardless of immigration status, and everything that comes along with the provision of that health care, cultural and linguistic appropriate workforce and service provision. We are also very interested in improving those environments where people live, work, learn, and play so that these environments promote health and keep people out of the clinical setting in the first place. What we really feel is that we are actually working against a sense of what's normal. And, you know, it's refreshing that this hearing is something that's holding up that what others may perceive as normal is not normal. It should not be normal that school dropout rates, when we look at those, that's a strong determinant of health. Whites, you know, they drop out at 7%, Latinos 14%, Native American Pacific Islanders 14%, Native Americans 17%, and African Americans nearly 20%. To me, this is root cause. Incarceration rates, this is an outcome that I'm also very interested in. For whites, incarceration rates are approximately 380 people per 100,000. For Latinos, that's 966 per 100,000. For African Americans, this is 2,207 per 100,000. And if we start, I'm also very interested in this issue of diabetes in the Latino community. 55% of Latino adults are either diabetic or pre-diabetic in California. That's a travesty. 43% of Latinos who are hospitalized have diabetes. They may have gone in for another reason, but they have diabetes, which expands the cost of the care. And when you look using a socio-ecological model, and you started to mention social determinants of health, and others here have mentioned that, we know that the roots of school dropouts, incarceration, community violence, and diabetes are very similar. It's disinvested communities. Senator Hernandez, you also talked about the zip codes and life expectancies in zip codes. These zip codes that are under-resourced are also the ones that have the highest dropout rates, the highest incarceration rates, and the highest rates of diabetes. So there's something bigger here, and we really need to get at root cause, and that's what a lot of our work is focused on. So I have a hard time explaining to my family sometimes, I'm the executive director for Latino Culture for a Healthy California. Why am I working on immigration reform issues? The reason we do that is because there are families that are being torn apart, and when they're torn apart, the economic stress on them goes up, and the physical stress goes up, and that ends up having negative health outcomes over the long term. So, at Latino Culture for a Healthy California, I'm really proud to be sitting here with our partners and also raising this issue of working against what people perceive as normal. It is not normal that 55% of Latinos have diabetes or are pre-diabetic. It's not normal that if you're poor, you have a 10 times fold of needing an amputation than if you're not normal. We need to continue to work against these things. So those are our priorities for the year.
Thank you very much. We're going to move on to Jonathan Tran.
Joint Health Committees. My name is Jonathan Tran. I'm the California Policy Director for the Southeast Asia Resource Action Center. We're a national nonprofit organization that advocates on behalf of Southeast Asian American refugees that have resettled here in the United States. I have the privilege, or unfortunate privilege, of sharing some of the news in regards to disparities that affect the Asian American and Pacific Islander population. I think first and foremost is to take a quick look in terms of the demographics of the Asian American community. California is home to the largest Asian American Pacific Islander community throughout the entire country. Additionally, California is also home to the largest resettlement of refugees anywhere around the world, and we're a significant component of the population that makes up a minority majority state here in California. Within the community itself, there's also tremendous diversity. For example, Southeast Asian Americans combined, Vietnamese, Cambodian, Laotian make up the third largest demographic within the Asian American community, following closely behind the Filipino and Chinese demographics. But oftentimes what happens with the Asian American demographic is that the lack of disaggregated data masks the challenges that our communities face. So I oftentimes like to characterize it, it's the best of times, it's the worst of times. And the chart you see on the right is the levels of uninsurance as it relates to racial demographics here in California. The coloring's a little off, but overall Asian Americans are actually below the statewide average in terms of uninsurance rates. But unfortunately, the lack of disaggregated data fails to give us analysis of what it actually looks like for community members. In addition to that, the challenges that many members in our communities face overlap with other immigrant and communities of color as it relates to specifically language access and cultural competency. So let's take a closer look in terms of uninsurance rates as it relates to the Asian American demographic. So right now it looks relatively good, like we're up below the statewide average. But if you spread out and look at the individual demographics within the Asian American community, you'll see that there's significant populations that continue to lag behind in regards to access to health insurance. In particular, the Korean American community has rates of uninsurance that are similar or parallel to the Latino community. This, in large part, is due to the fact that the significant populations within the Korean American community are also undocumented. So overlapping in terms of the push for health for all are Asian American demographics. In addition to that, you'll see other populations, in particular the Southeast Asian American community, that continues to lag behind in regards to health coverage. Unfortunately, the dialogue about health disparities, a big part of it is a quote I like from Confucius. Real knowledge is to know the extent of one's ignorance. So the diabetes data that I'm pulling on the left side are directly from the California Department of Public Health. And if you look at the statistics, Asian Americans are doing relatively well in terms of the rates of diabetes in contrast to other communities of color. What isn't reflected in the department's data is the fact that nearly 1 out of every 4 Hmong and Cambodian Americans will have contract diabetes. Even worse is the fact that we don't know the number of Hmong and Cambodian Americans that are actually being served right now by the California Department of Public Health's Heart Disease and Diabetes Prevention Unit. The legislature has allocated millions of dollars over the last couple of years specifically to this unit. They do tremendous work in trying to prevent heart disease and diabetes, but we still do not know to this day how many individuals that take part in that program are actually Hmong and Cambodian, given the fact that nearly 1 out of every 4 Hmong Americans has diabetes. This is even worse so if across the board, if you look at socioeconomic and educational attainment rates across the board for Asian Americans. The other piece of it I want to add is the fact that for Hmong, Lao, and Cambodian Americans, those demographics have the highest level of eligibility for Medi-Cal. But as it currently stands, the Department of Department of Healthcare Services does not collect statistics about the number of those individuals that are actually enrolled in the Medi-Cal program. I'd like to share and wrap up my portion of the program with some recommendations. Late last year, CRAC completed a survey of lessons learned from the first year of implementation of Cover California. And we come to you with 2 primary recommendations. The first and foremost is to partner with community-based organizations that have the trust of community members. I say community-based organizations because, unfortunately, if you look at the funding streams that are allocated after it leaves the state legislature on a county and local level, those resources are oftentimes not absorbed by organizations that serve underserved populations. They are oftentimes absorbed by larger organizations that have the ability to compete for county and citywide funding sources. But the populations that need them the most are not getting those resources. The second piece and the key recommendation that Assemblymember Rabanta had mentioned earlier, especially with AB 176, is a need for disaggregated data, both at the California Department of Public Health, but additionally with the Department of Healthcare Services, so that we understand the populations that are utilizing the services that the state is already funding.
Thank you very much. We'll now move on to the last presenter of this section. Please proceed.
Thank you. Good afternoon. My name is Ayako Miyashita. I'm the HIV Law and Policy Fellow at the Williams Institute, located at UCLA School of Law. Thank you for having me here today. The Institute's dedicated to conducting rigorous, independent research and scholarship on sexual orientation and gender identity, both law and public policy. Many of our prior reports have identified disparities among LGBT communities across many aspects of life. Our focus today is on the particular health disparities faced by LGBT-identified individuals in California. So a few quick facts. Previous research has identified the following health disparities among LGBT communities in California. Heterosexual adults are more likely to have health insurance coverage than LGBT adults. LGBT adults are more likely to delay or not seek medical care. LGBT adults are more likely to have cancer. LGBT youth are more likely to be threatened or injured with a weapon in school and are more likely to be in physical fights that require medical treatment. LGBT adults are more likely to experience psychological distress, and LGBT youth are much more likely to attempt suicide. Men who have sex with men continue to make up the largest transmission category among people living with HIV, and even more importantly, bringing in what former presenters indicated, there's an intersectionality at work here. African American communities, particularly, continue to be disproportionately impacted by HIV, and so that overlap there among MSM and Black MSM is clearly identified. Historically, there's been a lack of standardized measures to collect sexual orientation, gender identity information in federal and state surveys. California, compared to many other states, is ahead of the curve. The information we do have about LGBT populations is available in large part to the inclusion of sexual orientation measures in CHIS, the California Health Interview Survey, since 2001. Other surveys that have included sexual orientation measures include California Behavioral Risk Factor Survey, also known as the California Adult Tobacco Survey, and California Youth Risk Behavior Survey. More recently, the Williams Institute has successfully worked to add measurements for gender identity to CHIS, and has successfully fundraised to have this measure included in the next cycle. An additional measure for adolescents will also be included, asking about gender nonconformity. With the inclusion of the measurements, California will be the first state in the country to collect gender identity data in a population-based survey of its size. So what's missing? Well, collecting sexual orientation and gender identity, or SOGI data, the way we refer to it, is vital to understanding health disparities among LGB and particularly T populations. While we may have some data with regard to health and health outcomes, such as the information I shared with you before, what we do not have is data that describes the LGBT experience beyond that point. We remain unable to capture the LGBT experience with regard to service provision, and thus we're unable to assess the LGBT experience as it relates to accessing health care. And I believe Assemblymember David Chu has introduced a bill this session to begin addressing this gap in data collection. And we just wanted to share today that based on our experience with both state and federal agencies in both making the case for data collection on SOGI measures and getting such measures included in large population-based surveys, we've found great success in creating and establishing ongoing collaboration with such agencies. And while you may be in the process here in California of identifying where inclusion of SOGI data measures makes most sense, we also urge you to think about the way in which survey questions could be made more appropriate for LGB populations. For example, language referring to a husband or wife may be better presented as a question about a spouse. In this way, data collection can be done in a way that no longer alienates LGBT community members, and it does not make it difficult to respond to such questions. We look forward to seeing how California continues to be a leader in this regard.